That's kind of like the difference between a bolt and a tack. And when we're talking about teeth, it's much nicer to use something that's closer in line with a bolt than to hold it in with something that's like a tack. To put it into more scientific terms, we talk about success rates. Success rates when we're dealing with implants is how long they're attached to the bone, if they attach to the bone, and how long they will last attached to the bone. And we usually look at this in 5-year periods. If the implant initially attaches to the bone, we will then rate it 5 years later as it's still attached to the bone, and then another 5 years later that it's still attached to the bone. With a traditional implant, the success rate at this point across the board, nationally and internationally, is in the high 90th percentile for implants in the mandible or the lower jawbone, and in the mid 95 percentile, around 95 percentile, for implants placed in the maxilla or the upper jawbone. With mini implants, they can't make that claim at all. The failure rate is extremely high with them over the long term. If you're having a mini implant, the odds of that implant being in your mouth 5, 10, 20 years later just isn't there. Mechanically, they tend just not to be long term. There happens to be thousands of different types of dental insurance companies, and lots of them will have different plans within that same company. So whether or not it covers anything beyond cleanings, or how much it covers for regular dentistry, or if it will cover for implants, is extremely specific. So you really need to check with your individual insurance company. In general, though, if your insurance does cover replacements, then they may not cover implants directly, but they would cover the alternative form of replacement that you would get, and then that benefit could be applied to our doing the implant for you, or the implant procedure. And mini implants tend to cost less money. It requires less skill. It's a quicker type procedure to be done. There's so much less involvement with putting it in, and that's kind of why the failure rate is so much higher. So they do tend, in most practices, to cost less, although I am aware of at least one specific dental practice in the Buffalo area that's known for placing lots of mini implants, where their fee for mini implants exceeds our fee for doing traditional implants. Actually, what I kind of relate it to is a bridge that we drive across. We have all different kinds of bridges. We have bridges that will cross a deep ravine between two mountains. We have bridges that will cross a river, or you have like the bridge that goes along the Florida Keys that's hundreds of miles long and is very low. Well, the way the implant relates to that is we would look at the bridge as your replacement teeth, but we would look at the implants as the abutment for the bridge. And all of those different types of situations that I mentioned have different needs for different types of abutments for the bridges, or the way they're placed, or how deep they're placed, etc. So it's the same way with dental implants. It's very much up to the individual situation where we're putting the implant and how many implants we need to place so we can have them as abutments for the natural looking teeth that we're putting on top of them. So at the conclusion of the implant procedure, you really are having some type of prosthesis placed on top of it because it's an abutment for it. And so you really should not be seeing the implant at all. So we can place an implant in a situation where it's replacing an individual tooth. So the implant itself would act kind of like the tooth root, and then on top of that we would place a crown or cap. We can also have a situation where there are a number of missing teeth in a row. So we can place a number of implants in a row, so take care of all of them. Or we can actually use it more like a bridge and place one implant at one end of the missing space and maybe one in the middle or maybe not, and one at the other end of the missing space, and then bridge the gap with bridge work or a ceramic restoration. Another use of implants would be underneath a denture. So for example, a lower denture has no suction. So probably this is the most common usage that I have for dental implants, is where we'll simply place 2 dental implants in the lower jaw, and then we have magnetic attachments so that when the denture goes in, it is magnetically attached to the implants and is held in with that. There's also a situation where someone doesn't have any teeth at all, they're a denture wearer, and they no longer want to be a denture wearer. So this would be a great situation where we would then place in each jawbone, depending on, or in just one if that's all they needed, 4 to 6 implants, and then we would make a restoration that attaches to them in a semi-permanent manner. By that I mean I'm able to take it in and out, but the patient doesn't on a daily basis. It would stay in their mouth for years and only be removed if they were having a problem with the prosthesis. They would come in and have their teeth cleaned. It's as close to having a new natural set of teeth as is possible. Well, the recovery time for an implant is not a simple question. The first step is that the implant has to be placed in the jaw. When we do that, we cover it up with gum tissue, and then we let the implant sort of hibernate in the bone. When we do it in the mandible, by the nature of the mandibular bone, the lower jaw bone, we leave that hibernate for about 3 months. In the upper jaw or the maxilla, because of the nature of that bone, it's not as dense, we let it hibernate in there for 6 months. At that time, we can then go back in and activate it, which means we expose the top of it and screw in something that's above the gum line. And now we give that a few weeks to heal, so the gum line, we get a natural gum line healing around the implant. From then on, the patient never needs anesthetic again when we work on it. The parts screw in and screw out, and we can fabricate whichever type of prosthesis we want to put on it, whether it's a denture or a single tooth or a bridge or an entire set of teeth. First of all, I have been placing implants since 1981, which is years before many of the current doctors were even born. So I've had a lot of experience with the development of implants and the different types of implants as the process and the materials have matured. It also means that it's a procedure that I'm as comfortable doing as riding a bicycle. My whole staff is geared to that. My main surgical assistant has been helping me place implants for about 35 years. So we have an extremely experienced team. And for not all, but the vast majority of the prostheses we're placing on top of them, we're able to fabricate them in our own laboratory right here. So you're dealing with a doctor as well as his team who has decades of experience and thousands and thousands of cases that they have done. And with all the experience that I've had and seeing so many things, I pride myself on my success rate, which is literally close to 100% success rate with implants at this time. As an aside, having been in this field for so long, I hold diplomate status in an implant academy too. They basically fall into 3 major categories, one with a subcategory. The simplest and least expensive method of replacing your missing teeth or replacing teeth that you hate and don't like, is with a form of denture. If we're just replacing some of your teeth with a denture, which is a removable appliance, we would call it a partial denture. If we're replacing all of your teeth with it, it is then called a full denture. Next is a situation much like we're replacing just some of your teeth, but this is with something that stays in your mouth all the time. And there are two different ways of doing this. They both achieve the same end, but they approach it from two very different directions. One is where we would be placing dental implants, as we've discussed, and then be placing some type of prosthesis that is cemented or screwed in permanently on top of it, so that you as a patient have no ability to take it out of your mouth. You treat it like a regular tooth, and clean it like a regular tooth, and come in and see the hygienist, have your teeth cleaned like regular teeth. The other method is where we are bridging over a gap, so that we are placing multiple implants and bridging over a gap. Or if you don't have that, you actually have teeth on either side of the missing space. We can then instead come in, as I said, from a different direction to achieve the same result by preparing the bridge or prosthesis to be cemented and anchored on your natural teeth. So there are a lot of different choices, and with a discussion with the patient about their individual needs and wants and fears, as well as how quickly they want to get it and the different costs associated with it, we can pick out the particular method of giving them a beautiful smile that fits their situation. Freud had numerous complexes that he talked about, and the first one was called the oral complex. It is so natural for people to have a fear of a dentist or fear of anyone working in your mouth. It's a very, very sensitive area. A lot of people are more concerned with that than their private areas in terms of having that exposed or someone looking in there or working on it. So the fear is very natural. And so I have concentrated my practice literally since dental school on being concerned with easing people's fears and overcoming their anxieties and allowing them to get the dental work done and get the smile of their dreams in a situation that is relaxing, that's comfortable, with a friendly staff. So by the use of sedation, we can eliminate a patient's fears and concerns and allow them to achieve the smile of their dreams in a wonderful, comfortable environment.